Our next presentation is by Ali Pirasteh. He's a third-year resident in our program, and his mentor is Dr. Anil Pillai, and his presentation is Conventional CT versus Quick Check CT Fluoroscopy-Guided Lung Biopsy, a comparison of success, efficiency, complications, and radiation dose. One moment before Ali starts, his project, last year he presented at this meeting, went on to win a research award at the RSNA. He closed the loop on his research. So Ali, we're looking forward to hearing this year's presentation.
Thank you.
Thank you.
Thank you, Dr. Morris. Good afternoon. I have nothing to disclose. So CT-guided lung biopsies are preferred over the open surgical method because they're minimally invasive, they don't require general anesthesia, and they can be done on an outpatient basis. However, they do expose the patient to ionizing radiation. Now, CT biopsy techniques come in three different flavors. The first one is a conventional CT. You can do it in the same suite. Operator stands here, patient is in the scanner right here. And the images are required via a helical technique. You get 6 to 8 diagnostic quality axial images, and which help you guide the needle towards the lesion. However, they are obtained at a high radiation dose relatively, again, diagnostic quality. And there are multiple interruptions throughout the biopsy because you have to position the patient, get the images, leave the room while getting the images for radiation safety purposes towards the staff, and then come back and adjust the needle. The second technique is called CT fluoroscopy. You acquire real-time images. The operator stands here. They place this foot pedal adjacent to the scanner. Patient's still here. They press on this foot pedal, they hold it down, real-time images here, guide the needle, and get to the lesion. Now, the downside of that is that it is high radiation dose to the operator, especially to their hands, and that has actually been shown in the literature. The third technique, which is a compromise, is a quick check CT fluoroscopy, and we're going to call it QCT. Now, there is no need to leave the room. The operator takes this foot pedal and puts it actually behind this radiation shield. They do a single press here, and what they do is they get 4 axial images obtained at a low dose. You can see current is about 30 compared to the 200. And they never have to leave their room. They adjust the needle, they get the lesion, they get the biopsy, and it's over. Now, we designed a study with the goals of comparing QCT and CCT, the conventional technique for lung biopsies, and evaluating the difference between success, radiation exposure, efficiency, and complications. Now, we did a retrospective chart review, all 2014 CT-guided lung biopsies at UT Southwestern performed by the same team of interventionalists was included. QCT was used at Parkland Hospital, CCT at the old St. Paul Hospital. We excluded 64 cases due to missing images in PACS. We didn't have the information for those, as well as non-standard CT protocols were also excluded. In terms of outcomes, we defined success as both technical and histopathologic. Technical success was defined as obtaining adequate tissue, and that was per procedure report. Histopathologic success was defined as if the pathologist was able to give us a diagnosis or at least answer the primary questions, such as cancer or no cancer, and hence eliminate the need for further diagnostic workup or other procedures. Radiation exposure, I should say, was defined based on the DLP, the dose length product, from the report page in PACS. You can see that every sequence is actually listed here. There is pre-biopsy workup, such as the scout, the helical images to see the lesion, and then a post-biopsy run to see what we have done to the patient afterwards. But this line here, stationary, is actually the biopsy DLP. We excluded all the DLPs from the pre- and post-biopsy workup. The reason we did that was it was essentially the same between the two techniques, and it was actually independent of the biopsy technique itself. Included all acquisitions with a needle inside the patient. That's when the actual biopsy was being performed. Complications were defined into 2 groups, none or insignificant, such as no complication or a small pneumothorax, where the patient didn't have to be hospitalized or get a chest tube, and then a second group where there was a significant complication, we had to put a chest tube, further intervention or hospitalization. Last but not least, efficiency of the procedure was calculated based on biopsy duration or scanner utilization time, and we did that based on the timestamp on the actual images from beginning to the end of the biopsy, as well as the scout image to the last image that was taken. There were potential confounders, of course, for all these outcomes. One is lesion dependent. The size of the lesion, the type of the lesion, the distance to the pleura, especially a separate category for lesions that abut the pleura, where you don't have to theoretically traverse healthy lung. You can see that between these two, this is relatively a small lesion, kind of deep in the lung. You have to use a longer needle. It's more challenging than a superficial one. You can use a short needle, get to it. Try to also differentiate between lesions that were under a rib, near critical structures, or close to a diaphragm, because those are considered more challenging to biopsy. Of course, it's subjective, but we try to be consistent. You can see that if you have a lesion like this that's next to the aorta, you go a little bit too deep and you're dealing with a complication, so there's extra time and care taken towards biopsying this. There are technical potential confounding factors such as patient positioning, type of anesthesia, needle size, number of images acquired to get to the lesion, and of course, the number of biopsy cores obtained, and also patient-dependent factors, age of the patient, how sick they are, what is their body mass index, as well as do they have background lung disease or not. In terms of results, these are the confounders that we reviewed. We had 112 included cases for QCT, 53 for CCT. On the left column, you have our confounders, p-values here. Essentially, BMI in person in patient, moderate sedation use, gender, everything was the same, except for average age in years. The QCT group of patients was 3 years younger than the CCT group. These are the other confounders. All the lesion-based factors were actually the same, as well as some of the technical ones. You can see that between the two groups, there was no difference between the lesion location, background lung disease, cavitary lesion, etc. What was different, however, was mostly technical. Median number of image acquisitions, it took about twice as number of image acquisitions to get to a lesion in the QCT group than in the CCT group. There was a higher percentage of using a larger coaxial needle among the CCT group than the QCT group, and on average, one extra core was obtained in the QCT group and the CCT group. We believe the last one is probably a pathologist's preference if they want a piece of extra sample while they're in the room we're doing the biopsy. These are the main outcomes. This is the average biopsy DLP in milligrams times centimeter, 31.2 on average for a patient in the QCT group. Compare that to 368 for the CCT group, about a lot less. And average DLP per image acquisition in milligrams times centimeter, every time you adjust the needle, you only use 2.7. CCT, you use 47, statistically significant. By the way, these results are adjusted based on the confounders using a propensity score, so we did account for the confounding factors. There is no difference in significant complication rates, median biopsy duration, average scanner time, or the success rate of the procedures. This whisker plot says it best. You have the distribution of patient population in the QCT group and the CCT group, and this is the DLP, radiation exposure, a whole lot less in this group than this group. However, you can also see that the number of image acquisitions is higher in the QCT group. Again, we're adjusting the needle more often in this than this group. Now, we conclude that when you compare to the conventional CT technique, quick-check CT fluoroscopy-guided lung biopsies provide for less radiation exposure to the patient. They're as successful, efficient, and safe, and however, they're associated with a higher number of image acquisitions to get to the lesion. We believe that this last factor is actually dependent on a couple of things which we couldn't address due to the limitations of the study. Number one was its retrospective nature. Using DLP as a measurement of radiation exposure, it's not true dose to the patient, but we believe given the huge difference that we see, it is more than adequate. And there is also operator radiation exposure that we could not measure. However, again, they're behind a radiation field. It's a very low dose technique to begin with. It's probably insignificant. And the difference between the hospitals and distribution of trainees, you have a lot of residents who are at Parkland Hospital. Not many residents are at Clements Hospital doing lung biopsies at this point, which means you have to teach them, which means you probably have to adjust your needle a couple of extra times, get a couple of more images. And we were showing that despite using twice the number of images, you're still saving on radiation, you're not losing efficiency, your complications are not going any higher. So, at the end, this is our project team. I had the pleasure of delivering the fruit of their labor. By the way, at UT New Clements Hospital, we don't do conventional CT for lung biopsies. We're actually using the CT fluoro technique, which is much better for the patient. Thank you for your time.
Questions for Dr. Pirasteh?
Thanks. Okay, when I have a tool, I tend to use it, right? So you've got this really cool tool. Do you think that there's an issue of looking at the case more because you can really easily?
We also believe that is a factor, yes. And
Okay.
This is completely subjective,
Right.
because we had no way of measuring it, but when I was talking to the interventionalists, the actual number of image acquisitions, they'd say, wow, we do it that often. And then we say, well, we don't realize it because the pedal is right there. You don't have to go inside and outside. It's so convenient to do one extra check. And one of the other interventionalists said, actually, I do know I use it more often, and I do it when I'm outside of the pleura. Because now, if I'm not radiating the patient that much, the cost of making sure my needle is going exactly where it needs to go out of the pleura in terms of radiation is nothing, so that when I'm in the pleura, I'm not mucking around. So I have a good route out of the pleura. I took a couple extra images, and then I go in. And they said, yes, I probably do use it more than if I was doing.
Okay, and then
different
which
technique.
one was more accurate in terms of getting a final diagnosis?
They're both 100%. And in terms of the pathologic success rate, is that what you're talking about?
Yes.
They're both 100% essentially, but we've got to be careful reporting 100% success rate when it comes to anything, right? That doesn't exist. Our definition, we have a pathologist in the room, as you know. So
Right.
if they're there and you ask them, do you have enough? And they say, yes. And chances are they have enough to tell you what the diagnosis is. And based on what we followed up, the diagnosis has not changed for any of these patients. But again, you got to be careful because your follow-up period is what? Probably a year and maybe less for some of these patients. And the other thing is that you can see a lot of them in the distribution. There were like 40 passes. If you have a lesion that you went in there, you couldn't get it, it's a cavitary lesion, you popped an emo, you're scanning, you're putting a chest tube in, and after that, you're getting the wall, it's not adequate because the pathologist told you, yes, the success rate is 100%, but it took a lot of needle passes to get that. So, yes, we have apparently 100% success rate, but definitely the cost is actually reflected in the data. So, I don't know if I answered your question or not.
So a late question. So what's the potential dose savings to the hands, to the operator then, with your technique, the quick check technique? Do you have any sense of that too? Because
Well, so with the quick check technique, they adjust the needle, they step back,
Right.
and their hands are behind it.
right.
So
So it's potential significant savings.
it's nothing. Dr.
Ali,
Chhabra.
yeah, that was a great presentation. I like it for the biopsies. I don't like it as much for the nerve injections because you have to measure it, and it's hard measuring there. I mean, somebody has to go back in the monitor and then measure it for you from the location of the nerve to the biopsy needle. So that's one problem. The second is you only get 2 or 3 slices, one center, one head, and one foot, and you may miss the lesion. So that's a tendency to get more and more images to see the needle in plane, which you may not have in plane. Well, my question to you is, did you guys measure the time between conventional versus QCT? Was it
Yes.
less?
Yes. Let me actually address your second point. You can actually get more slices if you want with that same radiation dose consecutively. You can tell it to give you, without going back to the helical gate, like 6 in a row. You can actually do that. And if you have the joysticks in the room, I believe you can actually scroll through them. But going back to the biopsy duration, 17 minutes, and scan utilization time was essentially 47 minutes for both of them.
So that's from the start to the finish.
This is from the time that the lidocaine needle went inside the patient until the last needle was inside the patient. This is from the time the scout image was taken to the last time you had to image the patient.
It actually should be more, but the data is what the data is. In my experience, this QCT gives you, you save quite a considerable amount of time going in and out of the monitor.
It should save you time, but at the same time, what you're seeing here is you're adjusting it a whole lot more often. Theoretically, it should save you a lot of time. But what we believe is happening is if you have a trainee sitting there and you're teaching him, that time is offset, as opposed to if you have a resident who hasn't done a lung biopsy for the first time at the Parkland Hospital, you're teaching them, it's going to take a lot more time than if you have a very well-trained fellow at St. Paul who has placed needles multiple times before and say, all right, let's do this. But yes, I agree with you. It should save you time.
One
Thank
more.
you.
No more questions? Thank you very much.
Thank you.